Welcome to video 4 of chapter 10, and we will look at normal emotions as well as a number of emotional problems. And first of all, emotions are obviously normal reactions to events in our lives. We all have them, we all experience them, but sometimes emotions go beyond adaptive response and they can interfere with ongoing development for children and adolescents. And we can classify emotional problems as being externalized, as involving externalizing behavior or internalizing behavior. So externalizing behavior is that you are acting out, lashing out, such as with aggressive or destructive behavior. So externalizing behavior is associated with anger and aggression, um, whereas internalizing behavior is directing your intense feelings inwards, which can create anxiety or depression. So internalized behavior is more associated with like fear and sadness. uh, these same events though could cause both types of behaviors, or like it's it depends on the individual. And um, for instance, males are more likely to you know turn their emotions into anger and aggression responses, whereas females are more likely to internalize their pent up emotions and turn it into sadness or fear or anxiety. Um, Difficulties with regulating emotions, as we are talking about in the last video, and also difficulties with using executive control strategies are certainly associated with these types of behaviors. So often, somebody that ends up with a emotional problem um, will, will be lacking in emotion regulation skills and effortful control type skills. We're going to look at a number of different emotions and certain problems associated with them. And we're going to start with fear and anxiety. Um, these two terms are sometimes get grouped together. Your book, you know, tries to differentiate them by saying that fear is a response to something specific, like a real event. Um, something has actually happened, or you're afraid of a certain person. So like it is, you have a fear because of an actual real event, whereas anxiety, mm, may be caused by anticipation of an event that may or may not occur. So you like when you feel anxiety, there may not be a real negative event, but you're imagining one that may occur. Um, so fear of things like loud noises or novel items, along with stranger and separation anxiety, appear during the end of the first year of life, and these kinds of fears may begin to show up first around 7 month mark or so. And for some children, it might be a little bit later, but that's when you first might start seeing some of these fears. So, like, somewhere between 7 and 12 months, you typically start to see these fears um, appear. And toddlers and preschoolers, moving on to them, they experience fear of the dark or monsters in the closet. Those are very typical fears. They're linked with fantasy, and you won't get those fears, you know, um, until the child has the ability to use their imagination and you know, uh, and so they can cruise. And well, I mean, it requires imagination to create, a fear of the dark, or imagining a monster under your bed or something. So it's kind of linked. What you find is that it's linked with fantasy play, or what we call pretend play, which usually starts around the 2 year mark. You start seeing children using their imagination and pretending that, some blocks are a castle or something, and it's after pretend play starts that you start to see these kinds of imaginative fears, because they both rely on the same kind of thing. So just like we don't see pretend play in a 12-month-old, we also don't see these fears appear in a 12-month-old, because they don't quite have the imagination to fear the dark or a monster or something like that. Um, okay, the fears tend to increase up until roughly around age 8, and then they start to go downwards. That's a typical pattern, at least. So sometimes, anxiety may build up to be great enough that it interferes with a child or adolescent's normal functioning, and could possibly lead to an anxiety disorder. In order to be diagnosed with anxiety disorder, the anxiety has to be very severe and long lasting. So it's not just that you experience anxiety about one thing and it's really strong, but it goes away in a week. I mean, in order to be an anxiety disorder, it has to be lasting for months, typically, at the very least. Um, it includes such things as separation anxiety disorder in children or adolescents. Um, this is separation anxiety disorder can start, at a young age, um, and really show up, throughout childhood. Uh, we've talked about separation anxiety before. It's a normal developmental milestone. We expect it to appear, around the end of the first year of life and into toddlerhood. But what you don't expect is it to continue, into the preschool years and then the elementary school years. This is when it becomes a disorder, where it hasn't disappeared as in the normal developmental pathway of a child. You know, separation anxiety is something that shows up for a while and typically goes away. But when you see a child, attending elementary school, let's say, and they're still showing anxiety, a separation disorder, or sorry, separation anxiety, then it's they start to wonder if perhaps it is a disorder, because it's longer lasting, and it becomes not age appropriate anymore. Um, okay. A couple of other ones I mentioned here: generalized anxiety disorder. You don't really find that with children very much, but certainly it can appear in adolescents. That's where you worry about nothing. You're not worried about anything specific. You worry about everything. Um, Social phobias can appear in late childhood and certainly in adolescence, um, where you fear certain social situations. Um, for instance, maybe like having to talk in class or something. There's a chart on page 377, and it lists about 5 or 6 different anxiety disorders. So I do expect you to take a look at that. One thing that they found is in studying anxiety disorders is that using fMRIs and looking at the brain, they've shown that the amygdala tends to be hyperactive in people that have anxiety disorders. Uh, the amygdala plays an important role in the processing of emotions, and it's been particularly noted to be involved in fear responses. And so it's not so it makes sense that it is involved in anxiety disorders. And so they once again they find that it's often hyperactive, meaning it's overactive, and this could be causing the anxiety disorder. So I mean they have linked it to a difference in the brain. Um, One thing that's related to anxiety disorders is depression. And so we're going to move there now. And I say they're related because anxiety disorder is the most common mental health disorder to co-occur with depression. Where a person has both of them. And in fact, the rate of co-occurrence may be as high as 75% of cases where if somebody is depressed, that they also have an anxiety disorder. So they go hand in hand. They kind of feed off each other. Your anxieties can cause you to get depressed because they're interfering with your life, and and when you get depressed, you may become even more anxious because you're anxious about your depression. So they actually they do kind of feed off of each other. Um, so sadness, as it says here, is a normal response to loss and disappointment. But depression certainly goes beyond normal sadness. Uh, it involves feelings of worthlessness and hopelessness, a lack of pleasure, sleep and appetite disturbances, and they can go either way. Some people sleep more, some people sleep less, some people eat more, some people eat less. Also, possibly suicidal ideas or plans, which is known as suicide ideation, meaning that you're entertaining ideas of suicide. So these are the normal um, symptoms of depression. Now, it's much more common in teenagers than in younger children. In fact, the teenager rate is approximately 11%, a fairly high rate. So among teenagers, that approximately 11% will experience depression, whereas for children, it's only around 1%. So it's quite different. Fairly rare in childhood, much more common in adolescence. Also, statistics show that females um, are about 3 times more likely to become depressed compared to males. And this is specifically among adolescents. So why does that gender difference exist? There's a number of reasons that have been put forth as to why female adolescents are more likely to become depressed. One reason is that um, a girl's reaction to the physical changes associated with puberty, for example, the weight increase that comes along with it, is often linked to lower body satisfaction, which contributes to higher depression levels. Whereas, males tend not to be as bothered with the physical changes of puberty. In fact, many males enjoy the fact that they're bulking up and getting taller and getting more muscle mass. And whereas, for females, because of societal expectations and things like that, often find it very distressing when their bodies are getting bigger. Um, so that's one reason, more body dissatisfaction that can lead to depression. Secondly, girls are more likely to experience negative life events compared to boys. Studies show that it's just it's somewhat harder to be a teenage girl overall than to be a teenage boy, as far as things like daily hassles and interpersonal problems. Um, Teenage girls tend to experience these more than teenage boys do. So, there may be just the reality of that there are more negative factors contributing to the female depression rate. A third reason, girls are socialized differently, um, in that they tend to internalize negative feelings, and this is part of their socialization and their upbringing, whereas boys are much more likely to express anger and frustration and acting out when you know, when they have issues. And girls are more likely to internalize and turn it inward. So that's take us back to the externalizing versus internalizing. Um, and because the boys acted out, it's kind of like they release that energy. I mean, sometimes it might be destructive release, but they it makes it less likely that they'll get depressed because they are releasing their negative feelings, whereas girls are bottling it up and internalizing them. Okay. Finally, a fourth reason is that girls tend to ruminate about their problems and failures more than boys do. And rumination just means going over it and talking about it and thinking about it and this is there's been many studies that show that females overall ruminate about problems and failures more so than males do, and that can contribute to depression. Okay, let's move on to anger and aggression. So most children learn to control their anger by channeling it in appropriate ways. However, some children are not able to control their feelings, and this leads them into conflict with others. Um, the typical pattern is that higher levels of aggression in younger children tend to decline as they get older. So, I mean, it's not uncommon at all to see aggression amongst preschool age children, for instance. They take things from each other, they push each other, they might kick each other at times, but it tends to decline and become more controlled as they move into the elementary school years. But as it says here, for a small subgroup, the levels remain high um, even as they age. And if they remain high, this can lead to a disorder. Um, we're going to look at three disorders that have to do with anger and aggression, and each one I come to will be a little bit more serious than the preceding one. So let's begin with ODD. Some of you may have heard of this before, oppositional defiant disorder. Uh, Recurrent pattern of negativistic, defiant, disobedient, and hostile behavior toward authority figures that persists for at least 6 months. So that's the definition of it. And here's a whole list of typical behaviors of children with ODD. I'm not going to read through them all, but you can see that a lot of it has to do with just defying adults and not following rules that are set by adults, arguing with adults, and you can see losing their temper easily and being annoyed and angry a lot, blaming others for things. Okay, um, that's oppositional defiance disorder. And one researcher by the name of Gerald Patterson, and he's mentioned in your book, he identified a pattern of family interaction, which he called the coercive family environment. Coercive, I always struggle with that word, coercive family environment. He says that this can contribute to this disorder. And the way it works is basically like at some point a child misbehaves and the parents try to punish the child, but they're ineffective. Perhaps they use too mild of a discipline technique. So, anyways, they give it a try. Let's see if we can, you know, um, punish this misbehavior out of them. But for one reason or another, they're ineffective, and so the child escalates their misbehavior because the parents were unsuccessful in disciplining it out of them, and eventually Gerald Patterson says that the parents may give up. It's like, oh, we tried to discipline him, and now it's gotten worse, and they just kind of throw their hands up. And if that happens, that pattern happens, and um, Patterson says that the child has basically won that sequence, and so they're more likely to repeat their misbehavior again. And then they'll enter another cycle where perhaps the parents once again try to do something and to discipline it, the misbehavior of the child, and again, if they're ineffective, then the child will just keep escalating, and it can just kind of build over time. So he kind of says that he's basically making the point that it may evolve around ineffective discipline techniques that could form a pattern that leads to this disorder. Okay, something a little bit more serious than oppositional defiance disorder is called disruptive mood dysregulation disorder, DMDD. This is a new diagnosis that came out in the last edition of the DSM-5. As it says here, it's a disorder in which children, okay, in which children with are, okay, it's a disorder where children are basically irritable and angry most of the time and in many different situations. It is, like I said, it's considered more severe than ODD. A child with DMDD will have severe and frequent temper tantrums that are completely out of proportion with the situation. So, some small negative thing happens and they just throw a huge, loud temper tantrum. So they're not, and it also says like in many different situations. So this child may be doing this at school and at home and within in the community. They may throw these temper tantrums in shopping malls because they ask for a chocolate bar and no one buys them one. And I mean, like, so little things can just cause very, very severe reactions. It's typically first diagnosed between 6 and 10 years of age. So this is not, we're not talking about, preschool children here. We're talking about elementary school age children that are throwing major temper tantrums. Okay, that's about all I want to say about that. So it's a new disorder. All right, something even more serious is called conduct disorder. It's kind of taking it to another level now. We can define it as repetitive and persistent pattern of behavior in which the basic rights of others or major age appropriate social norms or rules are violated. So now we're seeing behaviors like aggressiveness towards people and animals. So they're not, it's gone beyond just temper tantrums, property destruction, lying or thieving, as well as other serious rule violations. This is often seen, I would say, more in adolescence. It can start late in childhood. It's much more common to begin or to be diagnosed early in adolescence. As far as treating conduct disorder, they find that what's called a multi-systemic treatment is one of the more effective ways to treat this. And multi-systemic just means that you're treating the child or the adolescent like in the various systems in which they belong, like within the family system, for instance. So you treat the child as well as as well as enlisting the support of the family. So you might do family therapy. You also treat the child in their school context. So it might be about identifying what are some of the triggers that cause negative behaviors in the school setting, and you might look at you might look at the system of their community or their peer group, but you're trying to treat the child or adolescent not just that, not just uh, not just in a way that you're saying it's all their problem, but you're trying to kind of look at how can we adjust these contexts, these systems that this child belongs to to make things um, work better for this child or adolescent. So you might get the family to do things a little differently. You might consult with their teachers and but how to best help this child in the school setting. Anyways, this is as opposed to another form of treatment where the child gets sent away. So something like a boot camp style treatment where, and this is fairly common, where children with conduct disorder kind of get sent away to learn discipline in kind of like a military style boot camp where there's very strict rules. And the problem with that approach, there's two problems really. One is that you put a bunch of young teens together that have conduct disorder, and they tend to reinforce each other's delinquent behaviors. It's kind of like, oh, you did that. Well, here's what I did, and I mean, like they kind of swap stories, and if one of them misbehaves, another one might try to up the ante and misbehave even more. So sometimes they feed off of each other, and they can create a real negative environment. Um, the second problem is that even if the child has shown progress in this boot camp, sometimes when they return to their lives and they're back into their family and school systems, the triggers for a lot of their problems may be back in these systems. And so they started to behave fine in the boot camp. They come home and also, perhaps they have an abusive father. Who knows? I mean, like, anyways, or they've been bullied at school and they come back and they get bullied again. I mean, like, so if they return to the triggers that exist, I mean, you haven't done anything in the boot camp to get rid of these triggers, and so sometimes they slide back into their problem behaviors. Um, anyways, so the multi-systemic treatment is considered a better approach, treating the child within the systems that they live in and behave in. Anyways, that will do it for video 4 from chapter 10.